All right, before we start the next session, I just want to give a quick heads up on two events that are happening tomorrow. So tomorrow in the morning, we have an interesting session on what is called the Innovation Day, which is a project that is run by MSF Japan, and there is quite some interesting discussions happening tomorrow with a lot of interesting external organizations presenting on medical innovations. So that's happening tomorrow in the morning. Guys, can we please have you back? All right, so as I said, tomorrow morning we have an interesting session on the Innovation Days. So if you're interested in attending that session, please look up the event tomorrow on the MSF India webpage, and please register yourself so that we can prepare ourselves for the number of people who are attending that event. So this is happening tomorrow from 10 a.m. at Paraquine by Radisson near the Mulchan Metro. In the afternoon tomorrow, we have an interesting mapathon. And I don't know if you've heard about the Missing Maps project. Yeah, so we will get into the details of this a bit later, but the mapathon starts tomorrow at 3 p.m. and it goes till the evening. So that's also something interesting. Please look it up. All right, so to get into the next session, which is faster, lighter, cheaper, innovative tools during disease outbreaks and emergencies. So I want to introduce the chair, Pete Masters, who is MSF's Medical Innovation Advisor based at Manson Unit in MSF UK. Pete, all yours.
Hi. Before I start with the actual session, I'm going to talk a little bit about Missing Maps because the event that Prince mentioned tomorrow, because this was my baby for 3 years. Missing Maps is a project that addressed kind of critical gap in geographic data in the places where MSF and other NGOs are working. So spatial epidemiology, surveillance, logistics, all these things become much harder if you don't have good quality, up-to-date maps. And in a lot of the places we work, there's really no impetus for commercial mapping companies to provide maps. There's no Amazon home delivery, you know, there's no Starbucks. So the Missing Maps actually uses the power of crowdsourced volunteering. So I think more than 120,000 volunteers have now contributed geographical data by looking at satellite imagery and plotting where the houses are and where the roads are, and built pictures of entire regions to support stuff like epidemiology and surveillance. So if you have time tomorrow afternoon, it's really fun, and it's a really nice way to contribute to not just MSF and not just other NGOs, but local organizations, local business. Everyone has access to those maps. Okay, there's my plug for tomorrow. So I was asked to chair this session as it's the innovation session. I don't know if you know, but there's actually a satellite event to this one in London. I think it's called MSF Scientific Day Western Europe. And there's actually a split in 2 days. So there's an innovation day and a medical research day. And I was talking with colleagues about the weird split between these two things because they so often overlap. And we were talking about how to define the 2 days, and we wondered whether you could frame the difference as this. So where research seeks to answer a very specific question, innovation seeks to solve a very particular problem. And I think there's actually probably a lot of problems with those definitions, but I think what the people are going to present to you today, that's a really good definition. Like they're taking a very innovative approach to real problems that we're seeing in the field. Before I introduce the first one, innovation is by definition risky. So if we really want to think creatively about problem solving and about developing new approaches, if we really want to kind of push the boundaries of what's possible, we have to accept that there's risk, that there's a risk of failure. And not just a risk, there's a probability of failure. So failure is not necessarily a bad thing. In fact, it really should be considered a good thing, and it should be acknowledged and celebrated because failure can teach us as much as success can teach us. So I want to just highlight the one particular abstract because the presenter couldn't be here today. When we opened the call for abstracts for these days, we actually asked specifically to hear about the failures, not just the successes. And this abstract was the only one that put forward a failure. So the team was led by Suzanne, and the abstract was the failure of an innovative, low-cost, non-invasive thermotherapy device in treating cutaneous leishmaniasis in Pakistan. So I just think we should, even though they're not here, maybe they're watching online, I think we should give them a round of applause for being brave and presenting failure. Also, the abstract is in the booklet, so do have a read, and there's a really nice poster at the back. To the online audience, please, while the presenters are presenting, tweet in your questions using the hashtag MSF Sci SA. And you will be prioritized because you are the most important people at this conference. Okay, enough of me. So I'm going to invite to the stage Yogesh of the MSF Programs Department based in Toronto. So Yogesh is an expert in radiologic technology and public health and is passionate about the intersection of technology and medicine in the context of global health. And he's going to talk about smartphone-based real-time telemedicine. Thanks, Yogesh.
Thank you. Thank you for availing the opportunity to present on a smartphone-based real-time telemedicine for management of neurological emergencies, field-based quality improvement in ECAD. So I'm presenting this on behalf of my colleagues, as you mentioned. Before I start, I'd like to briefly take time to talk a little bit about telemedicine. I believe most of you, not all, are familiar with telemedicine. So there are different definitions of telemedicine around, and this one I particularly picked up from that has been adapted by American Telemedicine Association. So whenever there is information, communication, or technological tools involved to provide healthcare from distance, we call it as telemedicine. Broad classifications, there are two kinds of telemedicine, asynchronous and synchronous telemedicine. When the exchange of medical information happens in non-real time, more imagined kind of email conversation, it's been categorized as asynchronous, non-real time telemedicine, which MSF has been adapting or using since 2010. So synchronous or real-time telemedicine is when the interaction is more in real time, like in simultaneous exchange with or without involving medical devices. So this is relatively new in MSF and requires certain level of infrastructure to implement it and on a field basis. I'd also like to take an opportunity to mention that MSF Canada is the reference section for rolling out telemedicine services in various MSF projects, and we work transversely with all operational centers. Today, the project that I'm going to present here was done in Pakistan with the collaboration of Operational Center Brussels Medical Department. So as I mentioned, you can see the map of the Pakistan here. So Timurgara District Hospital, again, Brussels Medical Department is located in Khyber Pakhtunkhwa province. This is in a federally administered region up in north of Pakistan. MSF has a long history of presence in the region, I believe since 1986, but in this particular project since 2009. It is a Ministry of Health collaborative project where we are working to deliver maternal child health services and also managing emergency department. So what's the context of the problem? So neurological emergencies accounts for significant mortality and morbidity in Timurgara. A busy emergency department which takes into account between 10,000 to 15,000 emergency consultations per month. The turnover of medical staff, mostly the doctors, is very high. We did a need assessment before starting with this intervention, and there were 19 emergency doctors at that time, most of them fresh out of medical schools, did not have enough hands-on training on dealing with neurological emergencies. There was, in this case, the emergency department had access to computer tomography, which is not very usual in typical MSF project. This is considered as a sophisticated examination. Over prescription of CT, some problems with the compliance of CT referral and that of with the standard MSF guidelines, which were developed during the Kunduz intervention. So CT scan costs were also very high, and it's not basically about the cost, but wait time and significant risks involved when the patients are not adequately resuscitated and then transferred to CT facility, which was being provided by a private vendor, not necessarily within MSF facility. So we thought of introducing telemedicine services, a smartphone-based telemedicine, and how we can put in contact the emergency doctors with these specialists to provide emergency support 24/7 and to better support them in dealing with these emergencies. So the objectives of this sort of scale pilot project were very clear. The idea was to support the medical officers in dealing with neurological emergencies, increase in adherence of the guidelines, and that and also to improve the patient care with the specialist consultation to minimize the misfindings, because radiologists were not available immediately to interpret neurosurgeons. They were not available immediately, so the medical officers had to interpret the CT films on their own, and quite often it was a normative perception that quite a lot of findings were missed, and so the objective was very clear, that provide a text-based real-time neurocritical specialist advice to deal with the first 20 to 30 minutes when the patient arrives in the emergency department, and that are very critical. The medical audience here are well aware of that. So how we did this? A single smartphone with 3G compatibility was equipped with a telemedicine application. When I say a telemedicine application, the one MSF did not develop, but we took already what is existent there in the market. And it's important to mention here that the medical grade data safety requirement standards were met, and this becomes even more important to highlight this, because with the GDPR now coming into effect, the level of encryption and security that is required for exchange of sensitive medical data has to be taken into consideration. So the smartphone was always available within the emergency department 24/7. For telemedicine specialists in the area of critical care, neurosurgery, traumatology, and emergency medicine were added into a closed group to support the emergency doctors. Most of the consultants, in this case, 3 of them were based in North America, Toronto and Seattle, and one being available in Pakistan, but not necessarily always within the hospital facility. No radiologists were involved, because I already mentioned the objective was not to give a comprehensive radiological interpretation or assessment, but to support the ER doctors within first few 20 to 30 minutes within the department. And all the experts were involved were confident and were dealing with all neurological emergencies in their day-to-day life. So all neurological emergencies that the field medical team thought were considered for CT referral were considered eligible for telemedicine consultation. So we did this pilot project from 7th of December 2017 to 4th of February, so slightly less than 2 months. So what was happening is we did the descriptive analysis to assess the impact of the intervention. We approached it from an operational perspective rather than a focused academic research. So there was no baseline data to compare. So this project oversight ethics, a requirement according to the MSF ethics framework of innovation. So here are our results. There were altogether 155 consultations during the period, and the mean first response time was less than 2 minutes. That's why almost in real time. This could be debated because there was no interactive video conferencing, but it was basically a text-based, structured text-based approach that the field team was taking to send the information to the distant clinician who were available on the roster, and they tried to respond back as quickly as possible, which you can see. So 90% of the cases were consulted for validation of CT requests and also for the management advice. So not surprisingly, more than 50% were for traumatic brain injury, followed by 34% suspected stroke case, and 14% altered mental status. It becomes important to mention here that a stroke care facility available in Timargara District Hospital, very basic thrombolysis and this kind of interventions are not available there. So very conservative management, but for traumatic brain injury, there was an opportunity because neurosurgeons were available. So some minor procedures and like borehole or periosteal elevation, these kind of procedures were available there. So you can see that as per the telemedicine consultations, we were able to avert 11% of unnecessary CT. And this was particularly because the referral criteria was not complying with MSF guidelines. You see that the management advice was given for 61% of cases before CT, 89% cases after CT. You see that the discrepancy there, they're not adding up 100% because most of the cases received the advice even before CT and after CT as well. So it was not about just the validation, whether I should go for CT or not, but make sure that you adequately resuscitate your patient. You have done all the assessment, polytrauma assessment, well stabilize the case, and then only you send it. And after the case was received, the doctors took a cell phone shot of the CT film, and the interpretation best to of their level, but quite often the findings were more supportive for them after telemedicine consultation. So after each telemedicine consultation, the doctors were asked to complete an anonymous survey. Of course, there were some more questions, but we highlighted here the one that we get maximum responses. So we obtained 82 responses, so it was more than between somewhere 50 and 60%. So we found that 67% of them told that they felt better supported after the consultation. 41% mentioned that the consultation will lead to a change in management, and 38% mentioned the advice was new to them, and 40% notified of the findings that were missed earlier. It becomes important to mention here that when they say the consultation will lead to a change in management plan, probably the medical doctors were aware that they didn't know about this management, but they might not have implemented that if they wouldn't have consulted with the telemedicine specialist. But 38%, when the advice was new to them, they were completely unaware. If they hadn't gotten the chance to consult it with the specialist, probably they wouldn't have implemented. And what was very interesting was the 40% that they thought the CT was normal in that case, or they were notified of a finding they did not see absolutely. So what's our conclusion out of this small scale pilot project? First, it is feasible to make available this kind of tool and to provide 24/7 coverage by specialists, giving them expert opinion, neurocritical care in a typical field context like Timargara. We also got a proof of concept, this could be debatable, but that real-time telemedicine improved to increase the adherence to clinical guidelines, make sure that they are implemented correctly. Reduction in unnecessary CT scans, we necessarily did not approach with this approach like a cost comparison or something, but there was significant reduction in number of unnecessary CT referrals. So guiding the timing of the CT was heavily noted in this case, and it positively influenced acute patient care. I again mentioned it positively influenced because there is no baseline for the comparison, but it's all of normative perception or perceived value by the doctors at the field. And most important of all is that the medical officers felt better supported and learned from telemedicine consultants. We did put in the survey about whether they did not find it absolutely useful, or was there any such of the bad experience of using the telemedicine consultation. So far the responses that we received were not worth mentioning. So conclusion, again, this was not a formal study, so we definitely need further studies with large sample sizes in order to explore additional usefulness of such an intervention, especially in the humanitarian medicine context. Finally, I would like to acknowledge our Pakistan project team and coordination team in Islamabad, and all the supporters of the clinical consultants and our colleagues at MSF Canada and Medical Department Brussels. Thank you.
Cool, thank you, Yogesh. Okay, next, Martin de Smet, doctor who started at MSF 27 years ago. I hope he doesn't mind that I say how long. It's in the bio, so I thought it's public information. He leads the malaria working group and coordinates MSF's malaria research project in Cambodia. Apparently, if you survive MSF for 27 years, you get to speak twice. So Martin's going to present 2 abstracts in a slightly longer session, and I'll let you introduce what those are.
So thank you very much for that introduction, Pete, and good afternoon. So in that first part of my presentation, I'm going to share with you how we have been monitoring the drug efficacy in our malaria project in Cambodia. Let me first say a few words on the project itself. So the project we have in Cambodia, the objective is to develop and to evaluate strategies to eliminate falciparum malaria in an area of artemisinin resistance. So we mainly focus on the falciparum malaria because that's the serious form of malaria, and that's also the type, the species of malaria that is affected by that resistance. And we focus on artemisinin because artemisinin is today the most potent, the strongest drug we have to combat malaria. So it's an essential part of the ACTs, artemisinin-based combination therapy, which today is the standard treatment for malaria since already more than a decade now, all over the world, I can say. So we went to Cambodia. We opened that project to avoid a further spread of that artemisinin resistance, or at least to contribute to that, because everybody is very concerned. We know from the past that the resistance to all the older antimalarial drugs, in fact, all originated from the Mekong area and then slowly passed on to the rest of Asia to the west, Myanmar, India, and then ended up in Africa. And if that resistance would end up in Africa, that would really be a nightmare scenario because we don't really have efficient alternative drugs available today. On the screen you see the project site where we're working, so it's on the border with Thailand, and we have data until April 2018. I just show you a couple of pictures just to give you an impression on what it looks like. So it's mainly small villages, especially during the rainy season, quite difficult to access. And most of the people are working in plantations in the forest where they do logging, hunting, other activities, and that's also where most of the transmission is taking place. Now, it's quite a large project with quite some components, and within the project, we have several ways to detect patients with malaria. We have in the first place the passive case detection, which means that a person with fever can address a healthcare worker most often a village malaria worker, a community health worker, for diagnosis and treatment. But next to that, we also do proactive case finding, which means the MSF team goes on a regular basis, monthly mainly, to the villages where we offer voluntary screening and treatment of the people who had risk exposure to malaria. So concretely, people having worked in plantations, having worked in the forest. And then there's still another way to get to identify malaria patients, and that's the reactive screening. So if we have a positive case, we consider the case as an index case, and we do screen the household, and we also screen the co-workers who have been working at the same place, for example, the same plantation where most likely the transmission took place. Now, within the project, we have a number of components that do address resistance or that have a link with resistance. The first one is on the public health level, because of course we want to make sure that in this project, the ACTs that we are using are still efficacious enough. Obviously, if this would not be the case, and we want to know this quite early, we should, of course, be able to consider alternative drug regimens, or if it would be doubtful, it would mean a good indication to say, no, we go for a full-scale, quite heavy efficacy study. And just for your information, a full-scale efficacy study is extremely heavy. For a single patient, this involves at least 10 blood samples that have to be taken over 42 days. Heavy for the patients, a high threshold to initiate these studies. So we're very much interested in something simpler. Now, the second point is more on the level of the individual patient. So, of course, we want to make sure that the individual patient is treated well and indeed clears the parasites, in the first place, of course, for the sake of the patient, but also because we want to avoid that a patient not responding well to a treatment and so more likely to be infected with a resistant strain continues to contribute to transmission. So within that project, we have developed a strengthened case management patient monitoring system to make sure that there is indeed a good individual follow-up of the treatment outcome. In the first place, again, to make sure that the patient is cured, but also to avoid that he further contributes to transmission. And so having that strengthened patient management system, this in fact led us to the question, if we would now structure this a bit more, could we not use this as a methodology, an alternative methodology to monitor the efficacy to the drugs rather than going to these heavy, costly, full efficacy studies? So let me maybe first explain what I mean when I say we have a strengthened monitoring of the patients. So if we have a malaria patient, usually detected by a rapid diagnostic test, we take an extra drop of blood on a filter paper, so a dry blood spot, and this is sent to the central laboratory in the capital, which is the laboratory of the Pasteur Institute. Then we always give 3 days fully observed treatment to the patient, because we cannot afford in an area with resistance that the treatment adherence would not be optimal, or at least that we don't give the maximum opportunity to have a good treatment opportunity. And we have been using over time 2 different ACTs. So the first one was dihydroartemisinin piperquine. That was the first line treatment until January 2016. And because of the very high resistance, we had to switch to an alternative ACT later on, and that's the artesunate mefloquine that we're using today. So we follow it for 3 days. And on day 28, we trace the patient back and we take again a dry blood spot, so a drop of blood on a filter paper that we sent again to the laboratory in Phnom Penh. And within a study, we did the same on day 63, where we traced back the patient once more, and again, we took a drop of blood. Now, we have a number of specific research questions in that project linked to the resistance. The first one is, of course, we want to see the outcome. We want to make sure that the ACT that we are using is still efficacious, so that's something we definitely want to see in an early stage. Secondly, as we follow up the patient at day 28 by PCR, we want to, in fact, to document if this is a good indicator to monitor efficacy. And then another technical question, should all the patients be included in the analysis, also the patients with a low parasitemia level. I'll explain that and I'll come back later, because I will come back to the three questions now one by one. The first and most important question, of course, is, are the ACTs that we're using still efficacious? So if you look at the first row, you see the period where we were using DHEA paraquine as our first-line ACT. You see the number of patients we have been following, and then you see the percentage of failures, parasitological failures, so people who still had PCR positive, meaning they still carried parasites at day 28. And so if you see the figure, 36% treatment failures, that's of course extremely high. Now, by doing sequencing of the parasite, we can also see if the parasite at day 0, when we give the treatment, is the same strain as the parasite that we find on day 28. If it's the same parasite, we know that the drugs did not kill the parasites, and we say it's a recrudescence. If it's a different strain, we say it's a reinfection. Now, in this case, even more worrying than the 36 as such, is that the vast majority, 87%, were recrudescences, meaning the drugs did not kill the parasite. Obviously, with such a figure, no one could justify to continue the use of that drug. We had to switch to artesunate mefloquine, and if you look again at the treatment failures at day 28, only 7% treatment failures, and there wasn't a single recrudescence among it, so this was quite reassuring that today we're using the right drug. So the conclusion of that part of the study for us was very clearly, we can no longer, there's no way that we can justify to use further that DHEA paraquine that was the first line at that time. The second question is more a technical question, and that's if day 28 is a good choice. Is it an appropriate time to do that evaluation? Now, the reason for that question is that in the standard methodology, the World Health Organization's methodology, normally the follow-up of efficacy is done at day 42, and it's based on microscopy. But we are using a more sensitive test. We are using PCR. And also, we don't want to wait until day 42 before we can identify a treatment failure, knowing that that patient may further contribute to transmission. So to see if day 28 was not too early, we also did the follow-up at day 63. And so you see that, in fact, at day 63, we only had 7% positives from all the ones that were negative at day 28. And there was not a single recrudescence. So this means, in fact, there were no late recrudescences after day 28. So our conclusion was day 28 is indeed a good choice to follow the efficacy of the drugs. And then another technical question was, should we include all the patients or should we exclude the ones with the very low parasitemia? Referring again at the standard methodology, normally the patients with the parasitemia below 1,000 parasites per microliter are excluded from the analysis, because you can imagine that if you start very low and you take your drugs, that you may not have yet sufficient parasite density at day 28, and that you may not yet detect a treatment failure. So we did the exercise over again. So on the left side in black, you see exactly the same figures that I showed you already. But then we did the same exercise by excluding the ones that had that low parasitemia below 1,000. And we have these data because we're using quantitative PCR, and so based on that we have the estimated parasite load. We're not doing microscopy. And what we see is the treatment failures. Looking at the first row again, that was 36. No, we end up with 59, with the confidence intervals just touching. And so here the conclusion is that if we include low parasitemic patients, we may indeed overestimate efficacy or underestimate resistance. Which is important, because if in such a project we would only follow the patients that we detect through screening, asymptomatic patients, with usually a very low parasitemia load, if we would use these patients, probably we would underestimate the resistance. Now, on top of the in vivo follow-up of the efficacy. We also invest by checking for the mutations that do correlate with resistance. And so you see the different mutations that we're following that correlate to the different drugs we use, artemisinin, mefloquine, and piperacin. I just would like to draw your attention to two results. In the first place, the one that correlates to the artemisinin resistance, because that's the reason why we are there. And so the worrying part is that when we started, 60% of the patients carried that mutation. Today it's 92%, which means that mutation that correlates, not equals, but correlates with artemisinin resistance is really fully fixed in that area. And also interesting, we found 14% triple mutations, which was the first time that it was documented and that we also published. So conclusions for us were, first of all, the system is feasible. We managed to trace back 60% of the patients at day 28 by having a good relation with village workers, with the village leaders, with the patients themselves. PCR-based day 28 is a good indicator to follow the drug efficacy, and we should be cautious that if we include low parasitemic patients, we may overestimate the treatment efficacy. Now, what we showed there was quite important, practically speaking, because the fact that we could document that very high resistance to DHEA paraquine led to the fact that also our area, or the area where we were working as MSF, was also included as a priority area to switch to the different first line, concretely the switch to artesunate mefloquine. Today it's the national first line because we got similar results from other areas. And so about this methodology, we think that this is really a relevant methodology, at least in elimination or pre-elimination settings and where we have artemisinin resistance. Elimination setting, because that's where you have few cases and where it's possible to afford that very close follow-up of the individual patient, and especially where there is artemisinin resistance, because then it's still extremely important that we follow the efficacy of the partner drug, knowing that artemisinin is not fully working anymore. And so there we need really not maybe a real time, but a very rapid follow-up of developing efficacy. Now, the story of the artesunate mefloquine in Cambodia is in fact an interesting story, leading me to the second part of the presentation. Perfect, exactly what I had in mind. The second part, because in fact it's an illustration of using drug rotation as a way to overcome drug resistance, at least in this situation. So if we look at the history of treatment in Cambodia, before 2000 there were all kinds of monotherapies, including mefloquine monotherapy, and probably some more that are not on the list. But then in 2000 the choice was taken to go for ACTs, and artesunate mefloquine was taken as the first line treatment. But then it only took a few years before the study started to come out showing already a strongly decreased efficacy. And there was, in different sites, it ranged from 79% efficacy to 90% efficacy, while 90% is the absolute minimum threshold acceptable, for example, by WHO to justify a certain ACT. In other words, it only took a couple of years before the efficacy of the drug was basically lost. The government decided to stop the use of artesunate mefloquine and to go to DHEA paraquine since 2008. And the rest of the history, in fact, is what I presented in my first part of the presentation, that it only took a couple of years before there was again an incredibly high level and an unacceptable level of resistance to that drug, while mefloquine became again efficacious, leading to a change again in 2017 of artesunate mefloquine, again as first-line treatment, and I showed you the efficacy figures showing that it works very well today. So there are some more examples in the literature that indeed a drug can recover sensitivity if it's not used for some time. And so for Cambodia, it's because artesunate mefloquine had not been used for a number of years. And it's also not so easy to get access to that drug. It's only a single producer that is validated. But also with chloroquine, this has been documented. So when ACTs were introduced in Africa, there was a strong push to deregister and to stop the use of chloroquine. So in a number of countries, chloroquine was not used anymore. And then there are a number of studies showing that chloroquine has again an increased efficacy. Kenya, Malawi, Zambia, Mozambique. So a number of studies showing that indeed, if you really can stop the use of a drug, you may expect some recovery of the sensitivity. So we definitely do not expect that chloroquine will replace ACTs again, but at least it means that that drug can still be somewhere in the picture of possible combinations in the future. And then there's one specific point on mefloquine and piperquine, where there is a kind of mutual incompatibility between the two resistance. In summary, if you're resistant to one, there's less probability that you're resistant to the others. So my last slide is in fact, it's more questions than answers, and that's what's next in Cambodia. So could we hope that in the future, again, drug rotation would help us out? So that if we're not using DHEA piperquine for some years, could we use it again after some years? Personally, I'm not very convinced because it's still circulating quite a lot in the country. Some people advocate for multiple first line, meaning you use one drug in one place, another drug in another place, or a different level of healthcare. There are also some studies picking up again these old ACTs, artesunate amodiaquine, artemether-lumefantrine, that were not used in the country for quite some time, with the same reasoning. They have not been used, so maybe they gained again efficacy. And then quite some people do expect, in fact, a solution from a tree therapy, so meaning we're combining artesunate with two drugs, mefloquine, piperquine being the most attractive one, especially because of what I just mentioned, the incompatible resistance between the two. But the weakness of all these solutions is, of course, that it's still all based on artemisinin, on artesunate, while we're just talking about partial resistance to that drug. And so, in fact, the main hope is that something that's still quite early in the pipeline, but that new non-artemisinin molecules and combinations would become available, hopefully by the day that we're losing all these ACTs that today are available. So I'd like to thank the study partners, which is the Pasteur Institute in Cambodia, the national program, the population, the public health department, and especially the national staff of MSF in Cambodia, who does the hard work, including the harsh living conditions, spending time in the forest and so on. Thank you very much.
Great, thank you, Martin. So last but not least, we have Raman, public health professional and MSF epidemiologist. In his bio, you see he has a lot of interesting focuses for his work, including leishmaniasis and childhood malnutrition. But this presentation is on the evaluation of rapid diagnostic tests for dengue.
Thanks for kind introduction, Pete. Good afternoon all. So I'm going to present a lab-based study on evaluation of performance of commercially available rapid test for diagnosis of dengue in India. So just start with a bit of context. So as you all know, dengue is a viral disease. There are 4 serotypes available: dengue 1, dengue 2, dengue 3, and dengue 4. All these serotypes are capable of causing disease. And this virus is transmitted to human by bite of female Anopheles, female Aedes mosquito. And this disease range from mild dengue to a more severe form, hemorrhagic fever. And this is one of the most rapidly spreading disease in the world. For example, in 1970, there was only 7 countries reported dengue cases, and now it's over 100 countries reporting dengue cases. And nearly half of the world population is at risk of dengue. And 50 million dengue infection cases happen to globally. And in India, National Vector-Borne Disease Control Program reported 180,000 dengue cases and 325 deaths in last year. Of these 180,000 cases, 40,000 cases were alone from West Bengal state, where MSF was running a project on treatment of acute febrile illness with focus on dengue. This is where the idea of this study came from, because I still remember when we have like project and when we were procuring the rapid test for our project, and we have no evidence which test to take. So it was just a guesswork which test, because on paper all these rapid tests were looking good. So just about the disease, when you have infection of dengue, it takes around 4 to 13 days to get the infection. The symptoms range from fever, high-grade fever, chills, headache, rashes, muscles, and joint pain. In a typical dengue case, you will find these kind of symptoms like dengue fever with muscular pain. But a small proportion of cases get into more severe form, which is dengue hemorrhagic fever, where you have bleeding from nose, gums, skin, and you have blood in urine. And this severe form can lead to a more severe lethal form, that is dengue shock syndrome. And for rapid test, it's important to understand the immunology behind the test. So once you have infection and symptoms start appearing, in first 5 days, you have like high level of antigen. So this is NS1 antigen, non-structural protein antigen. So within first 5 days, the level of this NS1 is detectable level. After 5 days of symptoms, 5 days of onset of symptoms, the level against this antigen, antibodies start developing. So after 5 days, IgM antibodies start developing in the body of host. There are several tests available for dengue RDT. It could be virus culture, it could be PCR, it could be RDT, it could be serological test. But I'm going to talk about the RDTs. RDTs, so what should be the ideal RDT should have? First thing, it should be ability to distinguish with other disease, such disease with similar clinical presentation such as chikungunya, leptospirosis, typhoid. It should be highly sensitive. That is, it should be able to differentiate, correctly find out those who have disease. It should be rapid, inexpensive, easy to use, and use in the temperature more than 30 degrees Celsius. So RDT, we know that it is rapid, inexpensive, easy to use, and suitable for high temperature. But what we don't know is that it is sensitive and it is able to distinguish between other disease. So that's why there is a diagnostic dilemma here. So like in country like India, there is several other disease coexist in same area. So and there's advanced, as I said, there's more advanced tests available, qPCR, virus culture, but these tests are very time taking and required skilled workforce, which is not always there in the resource limiting setting. Say for example a PSC setting, you're not going to do PCR or ELISA test. Also, national program as well as WHO recommend NS1 ELISA and IgM ELISA based test for 1 to 5 days NS1 ELISA, and for after 5 days IgM antibody based ELISA test. And RDTs are there. So there are several RDTs being manufactured and marketed in India, but we don't know the reliability and performance of these RDTs. But these so performance of these RDTs is yet to be independently evaluated against the gold standard. There are some studies which do the independent investigation of this RDT, but very limited evidence from India. Also, this study may be particularly useful as I said that we have a program for dengue and we don't know which test to be used. And in future, if we have MSF have any program or dengue related activities, it may be, such kind of study may be useful. So the main objective of the study is to evaluate the performance of 4 commercially available rapid diagnostic test kits in the diagnosis of dengue in India. The broader aim is to generate evidence to improve the point of care diagnosis for dengue in India. About this study, so we used stored serum sample obtained from 2 tertiary care institute in Kolkata, Kolkata School of Tropical Medicine and Kolkata Medical College. And these serum samples was already tested for patients, and they were tested for NS1, they were either tested for IgM, depend on when the presentation of the patient. If it is within 5 days, they test for NS1. If after 5 days, they usually go for IgM based test. And sometimes then there is a confusion that patient history of fever is like 3 to 5 days, then they go for both the test, both NS1 and IgM based test. And we have these stored serum samples, and we have chosen 4 RDTs. So these RDTs were selected based on their availability in the Indian market, and also those RDTs who has both the component in the same cassette. Both the component means NS1 as well as IgM. So what we did, we compared these RDTs performance against the reference standard ELISA in the stored serum sample. So these 4 RDTs were multi-shot, dengue check combos, SD Bala and dengue day 1 test. So as a diagnostic, it is a diagnostic evaluation study. So all RDTs were used according to manufacturer instructions. Our 2 lab techs were trained on the instructions, manufacturer instruction. So there were 2 lab techs. They were independently doing the test. They were blinded of each other interpretation as well as result of gold standard. But inter-rater agreement between 2 lab techs was quite good. It was the kappa was 0.96, so it was extremely good. So let's come to main results. So we compare RDTs with the gold standard, which is ELISA test. And what we found out that sensitivity, as I said, that sensitivity is ability of test to correctly identify cases, those who have disease. So sensitivity of rapid test in NS1 based test, the sensitivity was range from 71 to 85%, which is okay, but is very substantially inferior to what manufacturers is claiming. And when we see the result of IgM based assays, the sensitivity even reduced down further to 20% to 50%, which is quite low. And what manufacturer is claiming is sensitivity between 95% to 99% in all the RDTs. So we also did a subset analysis of samples where the samples was tested for both IgM and NS1. We tried to combine the results. For example, if sample is positive for either NS1 or IgM, we consider it positive. And we want to see the results, how sensitivity can increase or decrease. So what we found out, if we consider that if reference standard is either positive for NS1 or IgM, we found out that mostly in all but one of the RDTs, the sensitivity gets significantly increased. Now I'm presenting results of specificity. Specificity is basically ability of a test to correctly identify those who do not have the disease. So what we found out, specificity for all the tests was quite good. Is bit matching with what manufacturer is claiming. But for diseases like dengue, specificity is not that much important, because if you have low specificity, that means you will have more false positive cases. That means you will end up treating more false positive cases. But because dengue, there is no specific treatment for dengue, treating more patients is not a big issue. So specificity was not an issue. We did the same thing. So those who we combining the result, the samples, a subset of samples tested for both IgM and NS1. We did the subset analysis. We found that if we consider only if NS1 and IgM both are negative as negative, then the specificity reduced in all the RDTs. As inherent to lab-based studies, our study also has some limitations. For example, we didn't check for cross-reactivity with other flavivirus infections. It was planned, but we didn't get enough samples to power the study. For example, we didn't get much of chikungunya sample, leptospirosis sample, confirmed samples. So this was major limitation of the study. Also, because it was lab-based study, so sample size was not stratified evenly between the 4 RDTs due to low sample volume of reference standard. For what happening when there was a samples available, stored samples, but because sometimes volume is too low, we are able to test only on 2 RDTs. sometimes it's only one RTT, sometimes all 4 RTTs were able to do. So that's why sample size was not evenly distributed in all the RTTs. Also, we do not know the serotypes of the samples, like DENV1, DENV2, DENV3, DENV4, because there is evidence that RTT's performance sometimes depend on the type of serotype in the community. So overall, we conclude that performance of all the 4 RTTs was substantially inferior, and that reported by manufacturers. NS1 based assay is still better than IgM based assay. So NS1 based assay, the range of sensitivity was 71 to 85%, and IgM based assay, the range was 20 to 50%. Specificity was in acceptable range. And we also find out that added value of combining dengue antigen test and antibody based test. So for example, what we recommend, if the patient came to us regardless of their history of fever or history of symptoms of dengue, we should go for both the, if we are performing RDT, we should go for both the test, both NS1 based and IgM based. And it's very crucial to do independent investigation study to determine the field of effectiveness. We also feel that such kind of study, if we publish such kind of studies, manufacturers can get a push to improve the quality of their RDTs for future generation RDTs. That's it. Thank you very much.
Okay, so questions. I'd just like to remind you that questions have a question mark on the end of them. It goes kind of up at the end. Please keep them short. We only have 15 minutes for these 3 interesting people to share their experience. So put your hands up if you have questions.
Peter Paul, MSF India. Question to Martin, and forgive me, I'm not a medic nor a scientist if I use the wrong terminology, but since you're talking about the resistance in Cambodia, and as far as I know, people have been talking for quite a few years about that. You also say that the pattern of resistance always goes Cambodia, Myanmar, India, then to Africa. So by just changing this in Cambodia, what is happening in the other places, and is the resistance pattern already going that way, or are we able to stop it indeed?
Okay, this works or it does not?
Now it should.
It's working. It's working? Oh, okay, good. Yeah, so first of all, today, in Cambodia, it's fortunately still partial artemisinin resistance, which means it's not full resistance. The same situation has nowhere been documented in Africa, and only very scarce information from Myanmar and Thailand at the border. So for the time being, it's quite regionally localized, which is also the reason why, in fact, the idea is you have to work towards elimination. What we do see is, of course, the spread of resistance to the partner drugs. So not the artemisinin, but the partner drugs, that we find it more and more in other places of the world. But for that, probably we'll have a solution. The worrying thing is that we did see in the Mekong area that it's not just that one day it popped up, the artemisinin resistant, and then geographically spread around, but that there's also de novo, so new places where this pops up. So it's a mixture of a geographical spread, but at the same time popping up in more areas by strains that are not linked, which means we have to remain very concerned that this will appear in also in other places in Asia in the first place, and probably one day also in Africa. So for most of the experts, it remains. Fortunately today, it's not yet the case. The question is when.
Cool. Hands up again. One here and one at the back on the left.
Thank you. Hi, Raman, this question is for you. What do you think are the implications of your study on the manufacturers of these tests? That is what I would like you to discuss, especially considering there are some regulatory authorities for these tests. And what is the future actions you're planning based on the results? Thank you. Sorry, I didn't introduce myself. Hemant from the union. Sorry.
Hello. Hello. Yeah. So basically, the manufacturers, for rapid diagnostic test, the industry is basically very unregulated. There's many publications, even WHO has done this study, that these RDTs are not good compared to ELISA-based test. That's why even Indian government, the National Vector-Borne Program, don't recommend these studies. So the implication of these studies that if we publish like in a bulk such kind of like studies, which are independent studies, and maybe manufacturers look at them and try to improve the next generation RDTs. And there's a trend that the future past generation RDTs, the new generations RDTs are becoming better. So still there is a hope. Imagine we have like RDTs as good as malaria RDTs. In future, if it can be happen, then what can be better than that in case of dengue?
Cool. Hands up again.
Yeah, hello. I'm Sonali Ved. My question is for Yogesh. Could you tell us some more about the other work that MSF is doing in telemedicine, and how is this particular project different from that?
Sure. So as I mentioned during my presentation, that store and forward telemedicine, which is basically an asynchronous communication, is being used by MSF since 2010. And this is the widely used form of telemedicine in most of telemedicine projects. Until now, we have given services to more than 10,000 cases, and this is provided through a secured telemedicine network through a dedicated web portal where the field team elevates a question, a group of clinical case coordinators, they do the triage and then make sure that it goes to an appropriate specialist. So there are a network of more than 300 volunteer specialists, sub-specialists from across the globe who are validated by MSF medical departments. Some of them are MSFers, some ex-MSFers, some from academic institutions. So that is the established form of telemedicine services that we are providing. Real-time telemedicine, interactive telemedicine, use of smartphone-based applications is very new. We have been doing in bits and pieces of these kind of interventions. One project where we are using a dedicated video conferencing channel for clinical case discussions to give pediatric support in Niger. That's been ongoing for the last couple of years. We're in the process of a rigorous academic standard evaluation in collaboration with McGill University. We are also using various other forms like this one I mentioned, smartphone-based telemedicine application, not only focused on a clinical care, that is definitely one of the most important aspects of it, but also as a strategy of remote support and management. So because of the kind of complex projects where we work in areas where access is very difficult, quite often the project team is on its own, and even our coordination team, most of the experts are not there. So in order to help them to take an instant decision, to create a separate clinical forum where they can exchange views and information. So these are the complementary solutions that are coming into places, but there are obvious challenges, mostly with bandwidth availability on the field. You cannot do interactive telemedicine if you have a choppy internet connection. So so this particular project, we thought and we recommended this technology based on a very thorough assessment, and we thought that okay, we keep it at a small scale, a smartphone easily available over 3G network. So let's see and try to obtain a proof of concept. It will work or not, and we find so far these outcomes. Thank you.
Maybe just to follow up to that. So in your conclusions, you found that it was a feasible system. But at the start, you said that there was some specialist equipment in Pakistan that made it possible to do it there. So what sort of percentage of MSF projects do you have the conditions where you could use the real-time mobile telemedicine?
Definitely, I don't have a very rational estimate on top of my head, like what percentage of a projects we would say that would benefit from this kind of real-time support. But each context is different. Here, we identified the main problem that how you instantly support the ER doctors there for instant decision making. You don't have the window of time that you have available is very less. in a different context, it could be something else, because we are getting requests from, again, Brussels department, and for their operations in Middle East, they are thinking that can we use it, the technology for antibiotic stewardship program. So a very different context. You don't necessarily have to give instant medical support at that time, but this technology could be used there. So when I say about the real time, or again, I can share you another example in Somalia, which is our remotely monitored project. So most of the time, the expat team is not based in Somalia, but they operate from Kenya. So how you to keep day-to-day contact with your clinical counterparts there, and remember here we are using sensitive clinical data for extent. So you need a secure channel for that, but you necessarily don't need a real-time support.
Cool.
So.
Thank you. Yes.
To introduce myself, Petros, last minute chair specialist. So for Martin, one question. Sorry, Martin, forgive my ignorance about malaria, but you know what I realized, and it was striking to me when I listened to your presentation about the future. You were talking about therapy, and that there are some studies ongoing, and that's what actually was striking, that it's only now, and I think one of these trials going to publish their results in this year, or it was supposed to be 2018 or something, if I remember well. So why it took so long for people to think about 3 drugs for malaria? Is it something related to malaria parasite itself? Was it complacency when we found this miraculous new artemisinin something back, or is something that you could elaborate? Thanks.
I think there were two things that delayed it. First of all, we felt reassured that we had at least 1 or 2. Okay, sorry. So we had the impression, or people had the impression for some time, that we had at least 1 or 2 ACTs in reserve. The paraquine was not yet widely used. We still have the pyronaridin, the Piramax, which is still in reserve. So let's say that the sense of urgency to have an alternative was maybe not so high. The second question that came up when they really started to consider tree therapy was, of course, the safety. And especially all these partner drugs do have an impact on the QTC time of the heart rhythm. So there was always the fear, if you combine these drugs, you may have a certain problem with your cardio safety of the combination. So the first step was, of course, all the safety studies that have been done. But until now, safety studies have been done, and in fact are rather reassuring. And so now the main question is, that's difficult to answer, and I don't have an answer. So either we consider the tree therapy as a last resort, a kind of reserve solution in case we would run out of ACTs, or the second one is people saying, well, we should not wait, and we should maybe just do as we do it for other diseases, maximize today already the efficacy of the drugs, and even in Africa, where today ACTs work still perfectly well, but just look into the future, maybe already go for tree therapy. So the whole discussion on tree therapy has been boosted. Know that at least the safety information has been documented, which was of course not so easy, but it's reassuring. So the door is now more and more open to tree therapy indeed. Yeah. Thanks.
Okay, we got time for one more. Is there anything from the online audience? Online audience, you're being very quiet. Anything else from in the room? Everybody wants to go home? Cool, well, thank you very much to all of you. Really interesting.